Hey, Chair Diaz, we are still waiting on a few more members. However, we do have quorum, so we can go ahead and get started, and you can take it away when you're ready.
Thank you so much, Katie. I think I will maybe start to buy a little more time for those members coming in. One thing, first of all, welcome everybody to our March Plan Design and Expenditure Committee meeting. One thing I did not get to last meeting that I do want to take just a brief moment is to comment on one of the written public comments that was received last month. So that came from a licensed acupuncturist with Zocalo Wellness, which is a clinic in Northeast Portland. And their base is comprised mostly of LGBTQIA plus community and patients of color, many of which have OHP. And they did want to let us know that there is indeed peer-reviewed literature out there to support their work, and also wanted to speak to kind of a more holistic view of things, and thinking of many of our benefits as not being separate, but a continuum. And when you take from one, you may increase the need of others. And the points that the example that they put out was in regard to healing their patients using a multimodal approach, including acupuncture, physical therapy, and mental health, and how when some of their patients lost some PT coverage, that it did increase the amount of need for the other for acupuncture, and it took a longer course of care. So it was a really thoughtful written public comment, and if you haven't had a chance to read that, I would encourage you to go ahead and read that. But I did want to take just a couple moments to speak to it. And I guess if we are good now, Katie, we can go ahead and move on to roll call.
Perfect. Thank you so much. We'll start with Debbie Diaz.
I am here.
Helen Belanca.
Here.
Chenwei Chi.
Here.
Dr. Rosemary Hemmings.
Here.
Angela McLeod.
Here.
Antonio Germain. Betsy Boyd Flynn.
Here.
Brian Frank. Eve Gray.
Here.
Gabe Andine.
That's me.
Jim McGee.
Here.
Jamie Osborne.
Here.
Julianne Horner. Max Kaiser. Mike Durbin.
Here.
Peter Abbey.
Here.
Peter Merritt.
Here.
Rob Passett.
Here.
And Tosh Rami.
Here.
Wonderful. Thank you very much. And back to you, Chair Diaz.
Thank you. So we will start up by taking a look at our agenda for today's meeting. Next slide, please. Oh, one more. So we will go ahead and first have staff review the feedback following our last meeting. And then we're going to have a really discussion-heavy meeting today, reviewing several potential straw proposals, starting off with long-term services and supports, followed by behavioral health. Then we will go ahead and take a break, and when we come back, get into the eligibility straw proposal. And then after we finish our discussions there, we'll talk a bit about our anticipated next meeting topic, which will be provider reimbursement, and thinking into some of the questions that we have, some of the resources we may need in order to answer some of those questions. And I will be asking if there are any volunteers that would be available to take on this topic, much as we had several of our committee members take on the long-term services and supports and behavioral health topics. We will go ahead and then move into reflections and next steps, and then wrap it up with some public comment. And I will kick it back for, oh, well, here we go with this again.
Just a little reminder to the committee of where you are in your continuum of work.
Yes. Thank you. And here we are in March, and then, yeah, I think we can go. Well, that's where we are. And you can see we'll kind of have a little bit of flux moving forward and see as long as some topics take might be more than anticipated.
And so I will cover where we are with feedback from the previous meeting. So the committee has asked that they would like to hear a little bit more about how countries are handling eligibility. A request for data around how many non-resident workers there are currently in Oregon that receive healthcare benefits from their Oregon-based employer. They would like input from the Department of Human Services on long-term services and supports in the Universal Health Plan. And further discussion is needed around provider reimbursement for behavioral health services, and would like a list of what behavioral health services are covered by OHP and what behavioral services are not covered by OHP. And staff is working to get that information from you, and we will present it to you next month.
Week, did you say?
I'm sorry?
Next week?
Next month. Sorry, no. Bringing you back, no. And so our next item is to review and discuss the long-term services and support straw proposal, and I will let Chair Belanca take away. Oops, sorry.
I'm not chair in this context.
I know. Poor Chair Belanca, committee member Belanca.
Thank you. So I hope everyone had a chance to see the straw proposal in the written materials. This is a very big and complicated topic. And our small group that discussed this was really interested in the idea of putting together something like a public option for long-term services and support, similar to what Washington State is doing. But it's a very big ask, and it requires a lot of background work and exploration of that. And so when we put these straw proposals together, just as a reminder, I've drafted something here, which the purpose of this discussion is for us as a committee to look at this and decide if this is generally directionally where we want to go. And then the idea is that we would bring it back later as a formal recommendation to the board. So I put down what I think captures our conversation, but if it's off, then this is our chance to edit it, change it, amend it, add to it, make it more clear to reflect what this committee thinks is an appropriate approach to long-term services. So next slide. So basically we have a slide on the straw proposal, I think, right? Oh, where's the slide on the straw proposal? It didn't make it in the slide set.
Oh, is it the one that I created though?
Mm-hmm. I'm not sure who created it, but it came with it was sent to us with the document.
Is it it's in addition to the document?
Yeah, it's a single slide that just is a high level summary of the straw proposal.
Just 1 second.
Okay, I can talk through it. But basically, just as a refresher, right now, currently in our current system, there are basically two ways that people get coverage for long-term services and supports. And that is to spend down your assets so that you meet income eligibility requirements for Medicaid. And that would, then Medicaid would cover the long-term services and supports. That's about half of the long-term services coverage in Oregon right now is Medicaid dollars. The other option is that people can purchase private long-term care insurance. And obviously there are different plans for that, and that would fulfill that need. But there's a very large gap in the middle of people who haven't purchased long-term care insurance and really would prefer not to spend down their assets to qualify for Medicaid. And it's that middle group where there is room for us to make a proposal. And basically I said, there are a couple of options in there that we could explore. So the official straw proposal would be that we leave those current two systems in place, that people who qualify for Medicaid would still be, based on income, would still be eligible for long-term care that way. People could still purchase long-term care insurance on the market, but that we would explore options for that group in the middle, which might include a public option, so where there would be a new revenue stream, perhaps an income tax or a portion of the income tax for the Universal Health Plan that would specifically go to a fund for a public option for long-term care insurance. It could be cost sharing. So maybe we would give the same amount of services that Medicaid provides to folks who don't qualify for Medicaid based on income, but we would ask them to cover part of the costs themselves, or other options in there. So basically cost sharing or a public option or some way of getting everybody access to long-term services and supports. We had originally talked about possibly pulling long-term services and supports out of the universal health plan altogether and just making it a separate thing. But it seems like, I don't know, that I'm not an expert by any stretch on this, but it seems like that is a really difficult thing to do in terms of federal and state regulations around Medicaid dollars. So it doesn't seem feasible to do that. So instead it would remain in the plan for those who qualify based on income. And then we need to explore other avenues for the remainder of folks. Oh, there it is. Wait, let's see. Did I get it? Yeah, so long-term services and supports for Medicaid would continue to be supported. The universal health plan would not provide long-term services and supports beyond what's currently available to Medicaid eligible recipients. And then we would establish a task force to study the feasibility of a cost-sharing public option. So either there would be a tax or people would just pay out of pocket for some portion of the care. Again, this is totally open to feedback, amendment, especially folks that were in the small group with me, if you think we captured the discussion or if you'd like it different. I don't know, do you want me to manage the hands? Jim, do you want to chime in?
Yeah, I just have one comment. I think you kind of misrepresent the middle when you say people who do not purchase long-term care insurance, because there's also a much larger group who cannot because of medical underwriting reasons. So
can you say more about that?
differentiate between, it's not just people who choose not to purchase long-term care insurance. It's people who cannot purchase long-term care insurance because of pre-existing medical conditions that make it price prohibitive.
I see. Okay, right. Yeah, so change it to, cannot, or do not, Betsy?
So just so that I understand, the implication of this recommendation, or the summary, would be that the task force would be seeking some kind of shared expense model, public option that the state could buy into, that would be in theory more affordable than what is currently available because the pool would be so large. Is that correct?
That's right. Yeah. So either like a public option insurance. So like what Washington's doing is it's a payroll tax, and then anybody who has paid into it for a certain number of years would be eligible to get some subsidized care. So it doesn't even Washington's plan doesn't pay for the whole amount of long-term care, but it takes a chunk out of it, right? They would get that payment from the insurance. So either something like that, where there's a revenue stream, like a new tax that puts together a public option, or it would just be a straight up cost sharing, that, you could sort of buy into the Medicaid version of long-term care by contributing a portion of the expenses out of pocket. I don't know which one is better. That's what the task force would need to explore. And we'd have to walk through different actuarial models of like how much that would cost, how many people we think would need that, how many people would choose that, and as has been brought up before, currently a lot of folks, because of the expense, are making do with family and friend and trying to care for their loved ones at home. And how many people then would, if there were such an option, maybe, there would be a greater proportion of people choosing long-term services and supports if there were some sort of funding. So there's a bunch of different scenarios that would need to be worked out in the modeling. Sorry. So
Robert?
Yeah, thank you.
Hello. Yeah, I would say that, definitely I think the main punchline of our recommendation was definitely this piece that people with expertise need to be the ones weighing in on that question, expertise and access to data. So in that sense, seems good. I do think like the way it's phrased is a little unnecessarily limiting in like the types of options that task force would consider. Having read through the document, it kind of seemed to me to lay out very clearly that the intention was to explore like a percentage of billed charges to the family and percentage of billed charges to the public option, whatever it is, method that I thought was like very unnecessarily limiting of what they would be considering. And I would also add that expanding to also explore what the possibilities are for expanding Medicaid eligibility for those services in a way that, for example, California has done in eliminating an asset test. So, being careful to kind of separate the asset from the income like requirements for Medicaid. When you spend down your assets, that doesn't make your income any higher or lower, but there's just the two questions for eligibility. And I know that states do have flexibility on those two questions. And I think that Oregon is not at the maximal amount of like allowing people to join the program, like depending on their assets. Which of course there are complicated questions around. We if people have millions of dollars of assets, then we want those to fund our plan. But yeah, anyway.
Great. Thank you, Robert. That's good feedback. And just to be clear, you're talking about broadening the language that's in the document, not that's on the slide, right?
I mean, cost sharing, public option, of course, it's all cost sharing. I mean, even the universal health plan is a cost sharing public, right? Because people are paying taxes and that's part of the cost. I don't know. Yeah, I thought cost sharing was a bit redundant, say, and like redundant in a way that implies some other specific type of model. Am I wrong about that? Like, do you think about the universal health plan as something different from a cost sharing model?
I do.
Different from what's here?
I do in the sense that, everybody pays in and then it's regardless of if you use it. And when I think of cost sharing, I think of you pay as you use it. You pay to, so not everybody.
So this is then saying something, more specific and limiting by describing it as cost sharing. Right. And in a way that that, for example, a public option that people could say buy, even just a public insurance option for long-term services and supports would then not qualify under this like definition of a cost sharing public option. Right. So the slide isn't totally. So the main thing is to get the document right. So right. Okay. So if the document is accurate, then we're good. But if it's so, but we'll definitely. I thought it was in both places. Okay. Yeah. Yeah. Absolutely. And Tosh.
Hey, can everyone hear me okay?
Yeah.
Okay, so kind of I have 3 points to make. First, kind of giving an example of what Jim was saying. Like previous stroke patients do not qualify for long-term care insurance. So this eligibility will prevent a lot of people from being eligible for long-term care insurance. With Medicaid, in terms of expanded Medicaid, 90% of the funding comes from federal, 10% comes from state. So with Medicaid dollars being cut, I don't know how much Medicaid will be able to provide the services for long-term care. So that's another concern that I have. I know like Rob and I, we gave some recommendations, but I think like at the end of the day, we need more experts to come in and weigh in on this. And perhaps like an additional committee who can look at like how this services will be provided, what kind of cost containment measures we can look at, and how it will be managed. I think those are like key factors that we need to explore before we can like say that it can or cannot stay within the infrastructure of the Universal Health Plan.
Absolutely. And yeah, it's absolutely on our list for things as our financial consultants come on board to look at. Just a quick note, you're right that the federal government covers 90% of Medicaid costs for the expansion population that was expanded as part of the ACA. But for basic Medicaid, it's about a 60-40 split, maybe 55-45 split at the state level. So so basic Medicaid is not. And then there, of course, have been threats to cutting Medicaid, but so far, I just want to be clear with everyone, there's not really any clear plan in place right now to cut Medicaid. We just met with the governor's office this morning, and there's a lot of language being tossed around on the federal level. Nothing is being proposed at the moment, so we are watching that carefully, of course, but I don't want that to be, we have to be careful about that. Chunwei?
Yes, at some point, we may also need to have operationalize what do we mean by long-term care. So for example, under Medicare Part A, it covers skilled nursing facility for up to 100 days.
Right.
It's a kind of short-term coverage of long-term care facility. And so we may, when we come to the point of the benefit design, we may need a clear definition of what do we mean by long-term care.
Absolutely. Gabe?
Yeah, thanks, Helen. As I read this and understand it, I think basically what this is doing is, and I don't use this verb in a derogatory way, but it feels to me that this is sort of punting the question of long-term care for people who are not in the currently eligible under the two existing sort of programs, and punts this to this proposed dedicated task force to explore it and get those experts in and, come up with some proposal potentially. But it's sort of for the purposes of our subcommittee, and I think for the overall Universal Health Fund Governance Board, it sort of takes this question out and sort of puts it in its own sidetrack for the time being. Is that
Yes.
accurate?
Yeah, I think that's accurate. And I think, in terms of our work with designing the benefits of the Universal Health Plan, what we're saying is that they'll be covered if you meet income eligibility requirements for Medicaid and clinical, requirements. They'll be covered. That's the extent to which long-term services and supports will be covered under the Universal Health Plan. So that's like, in terms of our job, what we're supposed to do is define, in terms of defining benefits. And again, it's open to discussion about, but our proposal would be that we limit long-term services and supports to only those who would otherwise qualify based on Medicaid rules.
So if we vote and approve on this proposal, we're only sort of simplifying our own work to some extent to say, all right, we're going to keep the status quo for the status quo, and we don't need to debate the nuances of who would be eligible or what the benefit would be, because we're offloading that work to a separate task force potentially to explore that and utilize their expertise for that. Correct?
That's right.
Thank you.
Anyone else have thoughts or questions on it? Debbie.
I had just one clarification. With the separate task force, is this something that's going to be happening outside of the work of the board and or running concurrently, or just somehow embedded within it? Just a little clarification there.
I was avoiding that question. Happy to have anybody else weigh in from staff or consultants, but my gut feeling is it would be outside of the board's work, that when we present our plan to the legislature, one of the recommendations we will make is that the legislature, independent of this board's work, establish a task force to study a public option or a cost sharing option for long-term services and supports, and that would just be a recommendation the board makes to the legislature, and then they would take it from there, and it would be a separate piece of work. I don't see this board being able to take it on, but happy for others to weigh in on that. Ooh, Tash.
I don't feel the same way about like not keeping it within the conversation of the universal health plan. I think like we've had a lot of members who have volunteered or applied for this different committees. We do have those volunteer pool. I feel like we can create a committee who can explore this and present the information to the board, and that can happen simultaneously. But I just don't think like we can afford to have this conversation without the scope of the universal health plan.
Mm-hmm. Yeah, so yeah, it's a good point, and I'm certainly open to that. If we have folks on this committee who want to sort of peel off maybe from this work, and so, or I mean, I don't know if you're willing to take both on, but you know, be established as a separate task force of the board, and go in depth on this issue and come back, you know, in 6 months or something with a recommendation. It would involve working with our consultants and our actuaries to, you know, to kind of estimate costs and kind of propose different models. So I think it would be a fair bit of work and will require some financial expertise that I certainly don't have. But, you know, in theory, our consultants could potentially work on that. But staff, Jenny, Anya, anybody, if you want to weigh in.
I would just say that in terms of the current consultants that we're bringing on, that might be outside the scope of work that we've brought them on for. So it would probably need to be an additional scope of work that we would either work with them on or put out another request for proposals to do that type of actuarial work, because I think it would be separate from the plan's actuarial work. But if Anya or Janine wanted to weigh in on, you know, their thoughts on the scope.
Hi, this is Anya. Yeah, I mean, I think it's there's good reasons for thinking of this as an adjunct to what you're otherwise trying to design as a healthcare coverage program. But there are some important distinctions in terms of what's the existing market, what's the existing array of payers, and I think most importantly, probably, what's the unmet need out there? And so when you model the cost of a long-term care insurance program, you have to figure out things like, how do you get people to start paying in before they need the benefits, if it's going to be a social insurance model? What's the array of benefits, which largely are not covered by health insurance? So we've gone through this whole exercise of sort of helping you see what's the comparison of benefits across health insurance plans. In this zone, it's really all about Medicaid, except as noted previously that that Medicare does provide post-acute care, some SNF care as part of their Part B benefit. But largely this is a Medicaid benefit administered by Medicaid under very strict rules. It's hard to get in. And so if you're creating some sort of entitlement, I think it's a different landscape, a different kind of analysis, and would be definitely outside the scope of what you've asked your consultants to do so far, which isn't to say it's not worth doing. It's just that it's a different scope of work and is pretty intensive.
Tosh, do you want to say more about why you think it should remain in?
Well, I think the problem that I am facing, and like there is no guarantee, like I don't want this to be out of the scope of the task. I don't know how to explain it, but it just seems like we want these people to be covered, right? That's the whole scope of this universal health plan, is for all people who, and we don't want a situation where people are stripped down to their assets and then they have nothing to do and then they qualify for Medicaid. And with like there is this fear of Medicaid funding being gone. When we looked at long-term care insurance, it's not a very stable market. So there's many ways that there's not a lot of protection for these people. And I think from my end, what I'm asking is more of to explore this and not just punt it to something else, keep it within our committee, not necessarily like this committee, but like create a different committee who can like explore this, because we are all volunteering our time, but at least like not punt it to something else, or I don't want this conversation to like just not end up anywhere.
It definitely won't end up anywhere. It sounds like you're operating under the assumption, though, that everybody will need long-term services and supports. I think we treat long-term services and supports differently than routine healthcare because, the idea that, you need a basic level of coverage sort of all the time just because you exist, and you need routine preventive care and, contact with a health system for urgent needs. So, but long-term care only affects about half the population, and then the majority of those are accessing it through either short-term accessing it through Medicare or then long-term accessing it through Medicaid. So it's actually a very small portion of the population that needs it, but it is crazy expensive. And I think it's telling that, commercial insurance companies don't cover it for that reason. Like it's so it's so expensive and so out of the scope of what people consider sort of routine healthcare that it's worth sort of considering as its own thing. I agree with you. Like, as we don't want to leave this population out. I don't think we will. I think there will be options for people, and we're certainly not going backwards. I mean, if we would maintain the current systems as they currently exist, and then we would be adding something to the current system, so it would be an improvement over what we have now. But I don't think it's feasible to have it included as part of the coverage we offer to everybody. It would just blow the costs out of the water in a way that's really unsustainable. So I hear what you're saying. I don't think it will be dropped. I really don't. This is a really important issue. And, I don't know how much detail to go into about this, but, at the bigger board level, we're thinking about, the current state of healthcare where we are now. We're thinking about what the future, like a universal healthcare system, would look like and how that would happen. The steps to go from where we are now to that are massive, right? We're not going to switch a light on and go overnight to that. There's going to be a whole slew of transitional steps to get us, if we are successful, to get us to universal health plan. And one of those little buckets of work that we have imagined is this whole question of what do you do about long-term services and supports. And those little buckets can be dealt with sort of independent of whether or not we actually get to a fully realized universal health system. And so it's a really important bucket that's already been called out as sort of a stepping stone of our work in that gap between where we are now and where we're trying to go. So I don't have any concern that it's going to get lost, but I think it is kind of beyond what we can do given the expertise and time needed.
Okay, Robert, then Eve, then Jim.
Yeah, to that point, I would just highlight that like the reason it's a separate market from my perspective and why it doesn't work as a market is just because it doesn't work as a for-profit industry, and that's like sort of the point of including as a social service. And I would just say, like, for me, I don't have the same confidence, I guess, that that excluding it from the work of the board would still leave it addressed in a way that is meaningful, just because I have no reason to think that's how that works. And I would just say that I think it's important that the board and we as a committee take a position on what how important we think it is that this be included, and that it that we do whatever we can to make that to support that recommendation, with the principles of the board and everything else. Just because, it is the role of this body to recommend the benefits for the plan. And then this body, together with the other committees, to decide what is and is not feasible, kind of comes back to that for me. And it's okay if the thing that we're saying we think is important that the plan have then goes into revenue and whatever and turns out not to be feasible. But I just don't think it's our role to kick something out and say that it's not feasible if it's something that we think is important, which I think for me it is. So that doesn't mean that we have the resources and everything to address it, but I do think that it's necessary to include a position, take a position that we're recommending be explored.
Yeah, that's a really great point. Let me just respond to that really quickly. I think I'm picking up on something that I didn't pick up on before. Just because we are allocating this work to a task force doesn't necessarily mean that it would be outside the work of the board. It could be a task force of the board. It would just be sort of a separate body of work. So we absolutely can recommend that the governance board establish a task force as part of the board's work to study this issue and come back with a recommendation. And that would require, separate funding, separate consultants. We could request that, and it could still be part of our ultimate recommendations. It's just, I don't know that our current board or this current committee has the expertise or the time or the resources to kind of come up with a useful recommendation about long-term care. So by carving it out, what I'm just saying is it just needs its own level of attention. It could be a separate task force that the legislature creates, as part of it, or if we wanted to keep it in the board, if that's a compromise, we could say it still is part of the board's work, and we could ask the board to create that task force and do that work as part of its recommendations. Is it taking it out of the board's work that's the problem? Am I getting at what you're worried about?
I think that does address my main concern. Yeah.
Okay, so we have Eve, then Jim, then Betsy, then Debbie.
Thank you. I both believe that this is a really important social issue for us to address. And I believe that we've got to have some limitations as a committee and as a task force in what we're trying to solve societally through the first go at this. I have a lot of question about whether we're even going to be able to afford kind of the traditional health insurance proposals that we're talking about here, let alone adding conversation about a new service that we haven't had covered under regular health insurance plans in the past. I would recommend that what we focus on is trying to transition things from a traditional health insurance system that is very, very fragmented to those same services in a kind of singular system, one that does not have all the fragmentation, and from there, work be taken up to potentially add services and benefits. But we have a real risk of not making anything happen if we try to bite off so much.
Thanks, Steve. Okay, Jim, and then Debbie.
I'd like to echo Robert. Am I on mute? No, okay.
No, we can hear you.
Like to echo Robert's sentiments. I kind of keyed in on the word punt because that's exactly what the Affordable Care Act did. There was a long-term care proposal in the original Affordable Care Act that quickly got deleted because it was just too challenging. I think we would do the world injustice by just ignoring the issue. And I think a task force, it may not solve the issue, it may not present a viable solution, but I think it would call attention to the importance of the issue and the inadequacy of the current private insurance market for even beginning to deal with this issue. My wife had ALS and died with it, and I can't imagine coping without the long-term care insurance that we did have, we're fortunate enough to have. And shortly after she died, I got an email from a very close friend of mine who let me know that he had been diagnosed with ALS. And so I quickly asked him what kind of support network I had, because I had an amazing support network of not just long-term care, but also friends and church and neighbors. And he had none. And a month later, he took his own life. And, this is a, we shouldn't diminish how this ruins people's lives. And I think just even assigning it to a task force, as you discussed, and just highlighting it as an important issue that needs to be kept in the sights of this effort, whether it presents an immediate solution or not, we shouldn't lose sight of it.
Thank you, Jim. Okay, Debbie and then Betsy.
Thank you. I do want to echo Eve's sentiments and also appreciate you, Jim, for sharing that. This is definitely a personal issue for me as well. I went through this with my mom in 2020 and was part of the spending down the assets. And I can't tell you how many financial institutions and businesses I lost my composure in trying to navigate that system. As somebody who is supposedly a part of that system, it was a humbling experience. And I would love nothing more than to not have a single person have to go, or family member, community, have to go through that. I believe it took years off my life. And sadly, she passed away before qualifying for Medicaid. And one of the first things I did was I actually called to get her off the wait list so that it could bump somebody up as quickly as possible. And on some level, I felt some relief that I didn't have to figure out how to pay for it. And that shouldn't be the first feeling that I have after trying to explore my grief. So that being said, I don't want perfect to be the enemy of good. And I think we have the opportunity to do some really good work here. And I don't want to see us lose that ability by, as Eve said, biting off more than we chew in this first round. And so I would definitely support there being a separate task force looking into this. And I do think it is realistically outside of the bandwidth of our current board capabilities. But I do appreciate everybody's vulnerability and thoughts on this. It's an incredibly complicated topic.
Thanks, Debbie. Okay, we're going to have Betsy next, but I just want to do a time check for the committee. It's 1:45 and this topic is to go until 1:50. So after Betsy's comment, we may want to take a look at what the committee is willing to move forward, or if we want to spend a little bit more time on this topic. So Betsy, please go ahead.
Sure. I just have a brief comment, and I waffled, as you might have seen, because I put my hand up and put it down and put it back up again. I feel like it's important to call out that the long-term services and support industry as we know it is not potentially the only model. And in fact, there is not enough capacity in that system to handle all the people we imagine might be covered in a plan like this. And so I think one of the reasons the task force would be appropriate is because it can look at things like what impact legislation like House Bill 1073, which is currently under consideration, which would allow family caregivers to be certified and compensated to care for folks who need services and support. Clearly, there is a continuum of need, and that would not cover, even such services would not cover people with more significant need. But, you know, I hesitate to want to put more people into a system that does not work. So I do think that in that respect, considering this question more holistically, which is outside the bounds of this group, might be a good way to go.
Thank you, Betsy. And so for the committee, does the committee have an idea on whether or not you want to put forward to the board this idea, or does the committee want to spend a little bit more time thinking about it, considering the options here?
Is it possible, Jenny, to do like either a thumbs up, thumbs down, fist of 5, or some kind of way to kind of quickly gauge that looking at everyone?
I think absolutely. So for any committee members that aren't familiar, fist of 5 is just showing whether or not you're in agreement. So a 5 means yes, you think this should move forward. 4 is you like it but need more information. 3 is you're very neutral on it. 2 is you're not sure but you're leaning towards no. Well, 1 is you're not interested in this, and the fist is absolutely not. You do not support this. So if we want to do a fist of 5 on moving this proposal to the board to take the long-term services and supports out of the UHP and out of the plan, not necessarily out of the board, and move it to a future state where there could be a task force set up to study it. Helen, does that represent what you want
Well,
to?
what I would say is a couple of things. One, in terms of the fist of 5 voting, if you vote for 2 or 1, that means that you could potentially be on board, but you feel like it needs further discussion. It doesn't mean you're against it. The only thing that indicates that you've thought about it and you're against it is a fist, if you hold up a fist. But if you hold up a 2 or 1, that means you need more time to discuss and ask questions about it. And then in terms of the proposal, I think what we should be voting on is the full straw proposal, which is leaving the current system in place, which is qualifying for long-term services if you meet eligibility for Medicaid, leaving there to be an option to purchase private long-term care insurance, and then establishing a task force. And I would qualify that the task force must remain part of the Universal Health Plan Governance Board's work, and that task force would be comprised of anybody interested from this committee, and then some experts and actuaries, anybody who can work through some models and numbers about it, and that work would take place separate from this committee, but would be accountable both to this committee and to the board as a whole. So that's what we'd be voting on, is that whole package of proposal. And again, if you're enthusiastic, 5 or 4, neutral is 3, and then if you have a lot of questions and think you're not ready to support it, and then fist if you're against. Okay, should we vote? Okay.
I will do the looking at everybody on the screen and try to gauge where we are. So I see 4, 4, 4, 4, 4, 4, 5. 4. It looks like we have a majority 5s and 4s.
Okay.
So we will move this forward. We will put as part of the final long-term or as part of the final straw proposal that goes to the board, that the task force will remain part of the Universal Health Plan. I think that's the only change that needs to be clarified in the straw proposal.
And then we'll broaden the language a little bit to include a number of options, including expanding Medicaid eligibility, cost sharing, or a sort of social insurance model. That those will be the ideas that would be explored.
And so we can move on to review our behavioral health straw proposal.
Thank you, Jenny. I wonder if it might be a good idea to pull up the actual straw proposal and just kind of go through that as well. But
sure. Give me just 1 second and I'll do that.
Yeah, no problem. And I have it pulled up as well, so I can get started on talking about it. But essentially, the plan for expanded behavioral health coverage would be to mirror current Medicaid coverage for both services and provider types. However, for all, there is there is also acknowledgement that a lot of these services, the costs are shared between state general fund and through the CFAA, which is the County Financial Assistance Agreements, in addition to Medicaid billing. So there would be need to be further conversations to see about that and acknowledgement that there will continue to be the need of funding through that. Once we get it pulled up, it will outline the services and provider types. There's going to be an emphasis on community mental health, school-based services, integration of behavioral health into primary care, crisis service coverage, and that includes phone, mobile, and actual crisis facilities, stabilization centers, really seeking those alternatives to emergency departments. And then in addition, case management and peer navigation to be allowed to some extent before full assessment to help with the backlog. Some of these services will need to be means tested. And it's important to point out that while the coverage will mirror Medicaid coverage, it doesn't mean that we're looking for Medicaid reimbursement rates. As you all know, provider reimbursement and subsequently incentivization will be a topic, future discussion of this committee. So I guess just taking a moment to scroll through that. This is basically kind of pointing out, I don't know if you all recall from last time, but the bar graph that was shown last time and the different services. Peter and Eve, I don't know if either of you want to jump in and highlight anything or anything that I left out there.
And Debbie, please let me know if you want me to scroll down further or if we're in the right place.
Yeah, I would just kind of continue scrolling down a bit. And then one thing I do want to, that isn't articulated here, but one thing that in talking with another one of our board members that I do want to point out is does not mean to undermine any current programs like the K plan that helps to Medicaid dollars for intellectual and developmental disabilities. So this does not mean to take away anything that anybody has, but to be an overall enhancement to what the current landscape is. And a starting point, really.
And if anyone from the committee needs me to scroll up or down, please just let me know.
Dr. Hemmings?
Yes, so I, took a look at this and I was just curious to see, so what is different from this? What's the difference between this and what is currently being provided under our current Medicaid system?
So my understanding is in part different within the Medicaid system, different CCOs have different coverages. So
Correct.
so this would need to, assuming this is a direction that we agree upon, exploring what those different coverages look like. In talking with Cheryl Ramirez, who unfortunately is no longer on this committee, she did have some recommendations for like Care Oregon in the Portland metro area as kind of a basis for more comprehensive coverage, but that would need some exploration as to the specifics of the coverage. What wasn't included would be, I believe, some degree of the crisis service coverages and the emphasis on that, as well as the peer navigation and case management before assessment. But Eve, please feel free to jump in.
As well as social determinants of health, which I think is what Care Oregon, expansive population health focus is a bit different, I think, than most other Medicaid programs, right? Where things around housing, air conditioners, those sorts of things are also covered as part of behavioral health in some aspects as well.
Yeah, the idea would be for not any current coverage to be lost, for this to be expanded upon.
Okay.
Eve, I saw your hand go down. Are you still? Oh.
So I'm just trying to clarify. So there's
sorry.
So there's not I'm just trying to clarify. So there's not currently right now a recommendation, are we asking for a recommendation of whether or not to expand the current benefits under Medicaid behavioral health as part of the universal health coverage, or decrease those benefits? What do we act, what is the acts right now, I guess is what I'm trying to understand.
My understanding is expanding some of those that aren't currently covered, but then also would need to be in the ones that are inconsistently covered or covered by some, but not all, we would have to explore what the best model of that coverage is.
And I think the other piece is just a recognition that Medicaid has significantly more comprehensive behavioral health coverage than most commercial health plans. So the lack of comfort that I think we had with going with the PEB plan as the plan that we would support for the universal health plan was to say, well, you know what, we'd take a cut to the behavioral health services that were available to people with higher needs because they're just not covered as comprehensively on the commercial side. So, the goal was to say we want to take Medicaid's framework for behavioral health coverage and PEB's framework for physical health coverage in order to get that more comprehensive, holistic care. There's not a whole lot in here that that would be an add from a Medicaid perspective. I think Debbie captured the couple of things, but most of this is already covered, at least partially, and some of the mandated services you can't use Medicaid dollars for. It has to be general fund. So then the question is, does that, I suspect that most of the mandated services will stay outside of the health insurance system.
Thank you, Eve. Jim?
Well, I think I've mentioned to this group that I have a grandson with pretty severe mental illness. And the only environment that he has thrived in was a group home situation. And I don't recognize anything like that in this list. And I'm not sure if I'm just not understanding it correctly or how that would fit in.
Wouldn't that be, oh, go ahead, Eve.
It would probably fall under residential. It'd probably be a foster home, so there's different levels of residential. Foster facilities are covered under Medicaid today for folks who qualify.
Foster is, so that's not like a home situation, that's outside the home, not like foster care.
So there'll be licensed foster homes, which are so
Similar to adult care homes.
Adult care homes. There.
Yeah.
Okay. Thank you.
Any other questions, comments? Opposition? Jamie?
Thanks. I heard you say out loud to emphasize or reward integrated behavioral health services, but I just didn't see that specifically called out in this draft proposal.
It's in that last paragraph, integrated behavioral health in primary care.
Thank you. I see it now. Thanks.
Very important. Don't want to leave that one out.
And just another thing to mention, I know I saw all the list of provider types here, and the commercial insurance, you know, they don't necessarily all allow all of these providers to provide care for behavioral health. So I think that's also another reason to use the Medicaid model rather than the public benefits program.
Excellent point. Thank you, Dr. Hemmings. Yeah, that was definitely intentional there.
So, sorry, I didn't raise my hand, but this is Helen. I see housing supports on here. Is this separate from the health-related social needs? Because we have on the list is residential mental health services and adult foster care, and then there's a separate one that says housing supports. And I'm just wondering if that better fits in the health-related social needs. Because I don't know because these would be the benefits that we would offer to every Oregonian, right? So I'm wondering if the housing support one belongs in health related social needs, where you would have to qualify for that based on eligibility.
Well, I think you'd have to qualify for it based on eligibility, no matter what. What I don't know, this would probably be a Cheryl question, is are these housing supports specific for people whose behavioral health disability prevents them from living independently, as opposed to being an income or like the HRSN benefit?
Mm-hmm.
So yeah, I think that I don't have those details off the top of my head, so I think Cheryl would be the one.
Mm-hmm. Yeah, how is this different than residential mental health services?
Can check with Cheryl. It was called out different. I feel like it was separately on the graph that was shown. It was called out separately for health-related social needs. So I think it's referring to something different, but we can get clarity on that.
And then I had another question. I think currently, if I'm not mistaken, a lot of these services are provided by like county agencies. These are these all, other than the couple exceptions you mentioned, Debbie, paid for by Medicaid? Because there's some, like I think the crisis lines and the school-based mental health services, are those county run? Like, are those getting funding from other dollars in the system other than Medicaid dollars?
Most of those services are primarily Medicaid dollars. Crisis lines, I'm trying to remember if we got a separate tax to support them. I don't recall right now. But there are Medicaid dollars supporting those and other crisis services as well. It is really under the Aid and Assist, PSRB. We do some treatment, but we also do a lot court-ordered things, pre-commitment. So anything that's court-ordered is not eligible for Medicaid reimbursement, but anything that's treatment-based is eligible for Medicaid reimbursement in those programs.
Right. I'm just wondering if it makes sense if they're currently funded by other sources to keep them out of the plan and keep their current funding intact.
They're split. So they're currently split in how they're funded, and we recommended that split continue.
Oh, okay.
Anyone else? Gabe?
Yeah, sorry, I've been sort of biting my tongue, deciding whether it's worth calling this out or not. In that last paragraph where you had just highlighted this sort of integrated behavioral health and primary care, I've been involved in Columbia County in a sort of what we call reverse integrated behavioral health program, where for select patients with severe and persistent mental illness, we actually bring the primary care to the mental health agency and deliver the primary care there, which has been an innovative model that has really expanded access to that vulnerable population that struggles to access primary care in traditional settings. I don't know if that's, and a lot of that, there are other programs like that around the state, many of which were sort of pilot funded through a federal program, and that are now sort of trying to find ways to remain sustainable. I'm not sure if that's worth calling out that specific type of model in the language here to bring others' attention to it, but it does seem like, in terms of the goals of the board and sort of expanding access to vulnerable populations, that it might be worth considering.
Thank you for that. I think there was an emphasis on wanting to meet people where they're at. Eve, do you have thoughts on that?
Yeah, I think what you may be getting to, Gabe, is the CCBHC model. Yeah, so we probably need a separate meeting where we talk about both CCBHCs and FQHCs, because in the way that our current model exists, CCBHCs and FQHCs serve high needs, vulnerable populations, and the payer mix doesn't typically support self-sustainability. So payer mix is highly Medicaid and a little bit of Medicare, and then a trickle of other things. So there are differential reimbursement models, both from federal and state sources, that enhance payment for these particular types of institutions in order to support the care for those vulnerable populations. In this new model that we're putting together, there won't be a payer mix. So you're not going to have to necessarily subsidize based on payer mix, but you may need to create subsidies based on the type of comprehensive wraparound care and supports that are provided for high needs populations. And so you may be redefining then what are FQHCs and CCBHCs in our system, and how are we incentivizing both those types of wraparound services, as well as matching the right patient to the right type of medical service within our community. So to me, it's a broader conversation that we should have in an upcoming meeting at some point to figure out how these types of clinics fit into the new system. I don't know, Gabe, was that what you were getting at?
Yep. Yeah, I'm specifically referencing what that CCBHC, and just like everything you said, it's sort of extra vulnerable population here, and the wraparound care that that doesn't pay for itself. It's a higher resource type of care coordination that's necessary for these folks, and I'm not sure how that fits into what we're designing here, but perhaps I'm biased, but I've seen it on the ground. I've seen the impact of this care for these patients.
Thank you, Gabe. Jamie?
Yeah, I would echo that. Thank you, Gabe, for calling that out. I would just say it does pay for itself. It more than pays for itself. It's a really, really effective model. And we've done something similar where we've pulled services into one location of our FQHC and but it needed upfront funding to pull all the resources in. Once you get the patient inside that lovely wraparound care, the cost plummets and the outcomes soar. So it's a very effective model.
Like the cost savings in terms of ER utilization, or yeah.
Exactly.
Mm-hmm.
Yeah. ER utilization and hospitalizations alone. I mean, and those are the cost savings that we're able to capture, but it does pay for itself, but it's a good call out to say that some upfront incentivization is required to get the ball rolling. Once it rolls, it goes and it goes.
Jamie, have you got the data? I mean, have you run the data locally to show the cost savings?
Yeah, we ran it with our CCO and showed them the cost savings, and then they reinvested in it because it was so stunningly successful.
Thank you.
Thank you both. Helen?
Given that, I wonder if we can just add a line in here about CCBHCs and just say that funding and sustainability of the CCBHC model will be included, simplified, streamlined, supported, some wording like that, where we call them out and say that, you know, the intent and the goal is to maintain the model, but simplify the funding and ensure that it's sustainable.
Jim.
As somebody who has made a lifelong campaign against acronyms, I hope when you report this out, you'll spell out what CCHBC is.
Certified Community Behavioral Health Center. But
I kind of figured as much, but I just, you know, calling it out.
Yeah, I think that would be a simple thing to include, and I don't think we need to, for the purposes of this straw proposal at least, and getting the direction of where we're headed and kind of like the thumbs up from the board to kind of keep moving in this direction. I don't think we need to have all the details, but the intention overall. Eve.
I would just say that at the point that we mentioned CCBHCs, I'd like FQs rolled in there too, because they're very similar models, kind of targeting slightly different populations, and it is similar levels of investment that are required, because though Jamie's absolutely right, total cost of care goes way down when you produce a model like this. It's a more expensive model of primary care, and you have to be willing to invest in primary care in order for the model to work. So I think that we need to talk about that more. I just don't want to call one out and leave the other hanging.
As someone who works in an FQHC, I support that. Anyone else? Check the time. Okay, we're good on time. So Jenny, I'm wondering if we can kind of go into a fist to 5 as far as moving this forward with the additions, I would say additions, tweaks, minor edits to reflect the conversation here.
I think so.
All right.
I think we will add the CCBHCs and FQHCs into this paragraph before it goes to the board, but otherwise keep this as the overall proposal.
And clarify the housing supports as well.
Thank you. And Jamie has a comment. Go ahead, Jamie. You're on mute.
I was just saying yes to clarify the housing proposal line, please. And just to clarify, before we ask for you to clarify, do we know what we mean by clarify?
Yes. Is this related to health related social needs or something separate? Which I feel like it came up at the last meeting, but it's escaping my mind of what the example that was given. But yes, definitely a clarification on that. And thank you for the clarification of the clarification or the specification of my clarification. All right. So fist to 5 as before.
Looks like we have almost all 5s, so we will move forward. Okay.
And Jenny, do we want to roll into break early and just tweak the time that we come back, and
I think
that way we
great
have
idea.
a little more time for eligibility?
Yep. So it's 2:15 right now. If everybody could come back at 2:25.
All right. Thanks everybody.
Jenny, I will need to leave at 3 o'clock to go to my class. I'm teaching this afternoon. Thank you.
Thank you, Dr. Chi. Okay, everyone, it is 2:25. So as you're coming back from break, please either come on camera or just give us a thumbs up to let us know that you're back. Okay, we're getting ready to start again after the break. Looks like almost everyone is back. If you aren't on camera, if you could just give us a thumbs up to let us know that you're back, that would be helpful. Okay, so we are moving into the next topic, which is the eligibility straw proposal. And we have Danielle with us. Danielle, why don't you go ahead?
Alrighty, thank you so much. I'm gonna start myself a stopwatch to make sure I'm being mindful of time. Alrighty, good afternoon, Plan Design Committee members. I'm Danielle Ross. I'm a policy analyst at OHA. And first of all, I just want to thank you again for the opportunity to continue this conversation with you around eligibility. First of all, although the agenda says review and possible vote, I want to clarify this proposal is not going to be ready for a vote today. Today, I wanted to invite more discussion from the committee members on some eligibility topics to make the most of the time that you all have together in this room. At the last meeting, we got into some pretty big questions. We asked you for your feedback in a breakout group, and we heard a lot of clear values. For example, you all seem to really agree that incarcerated people are indeed people. So there were some common through lines in those discussions. You guys also raised some more questions, and OHA staff is working on a plain language FAQ document to get you more answers before we ask for any sort of final decisions on this proposal. And that FAQ document we will present to you next time. It'll have some international comparisons and some policy analysis that reflects your priorities from your discussions. So the goal today is discussion. Not everybody got to participate in the breakout group last time, but we used that as a starting point, and I drafted the straw proposal that is in your meeting materials today. It's very rough. It's supposed to prompt your reactions and revisions and disagreements, just to make sure that we're hearing from all of the committee members and we're not missing people's input. You are experts on your experiences here in Oregon, and because of that, I want to be sure to ask you clearly, what do you want to see in the final version of this proposal? Are there potential areas for agreement? Do you want input from the board? This straw proposal would be a good way to ask for that. And while we discuss, I would say please keep in mind that these should be broad recommendations based on your values and the values of the board. And while these recommendations might change in the future, we're right now just trying to set some high-level guidelines to keep your work moving forward. Next slide. So for today, I'm just going to focus on the high-level summary section of the draft proposal, which will just be the next 6 slides. And that's just for time constraints. I divided this section into 3 perspectives, which is the patient, the provider, and the payer. The patient section is the most dense. And throughout these 6 slides, I'll offer 12 invitations for feedback. And when I invite feedback, I'll ask for a temperature check with the FIST to 5 method that you guys have already been using. So a FIST means I absolutely disagree, and a 5 means I completely agree, and 1 to 4 are varying levels of agreement. So if we get mostly 4s and 5s, I'll suggest we move on. If we're getting 0s to 3s, then I'll ask for your revisions and opinions. Next slide. Alrighty, so we're starting with the patient perspective. And according to our discussions last time, I heard that you want all residents of Oregon, regardless of income, including incarcerated individuals, to be eligible for universal health benefits. And residents who meet income, social, and clinical criteria to be eligible for enhanced benefits. And so I'll ask for a temperature check, fist to 5. Does this capture the intent of the committee members? Is this what you want? I'm seeing some 5s. Amazing. I'm getting a 0 from Mike, a 3 from Eve. Okay, then since we have some disagreements, I'll stop here and invite some feedback and ask, how would you revise this part to make it more clearly aligned with your intentions? Mike.
Thanks, Danielle. The only reason I had a 0 up was I don't know how I feel about it being income, social, and clinical criteria. If you meet just one, depending on the severity of what they're falling within that category, I'm wondering if there's people that could have that without meeting the other 2. I don't know enough what was discussed potentially last time because I unfortunately missed that meeting, but I'm a little hesitant with the and because I wonder if that's a little too prescriptive.
Well, thank you. Eve.
I just have questions around implementation with folks who are incarcerated. There's the funding question, which I think we looked at. So far, the state has said no on the provision of many types of medical care in jail based on CMS. So just making sure that we have the administrative capacity to separate funding in the way that would be necessary in order for that to meet criteria. And then the other question is, I want to make sure that we have an understanding kind of around what access to care jail commanders and prison commanders feel is doable, and that we not put a requirement for the ability to access certain types of care that would be not possible for them to deliver upon. So I think we would just need to be really careful with our partnerships and discussions with jail and prison leaders. And OHA is getting all of these connections right now. So I feel really confident that these things could be worked out. I just feel that we need to have clarity on a few points to make sure that we can cover all things for incarcerated individuals, and that there wouldn't still be a pot of money that covers benefits from the public safety system, which is how it works now. Is that it's not that folks who are in jail don't get health care. They do get, many would consider, a lower standard of health care. And so what does that look like in this new system?
Thank you so much for that. Helen.
Helen, you're muted.
All day long, I've been doing that. I'm so sorry. I wonder if we should not include any mention of benefits in a straw proposal about eligibility and keep the focus just on who's eligible, and let the benefits proposal speak to that. We eventually will have a full proposal on what the benefits look like. But I wonder if we should just narrow this focus to just who's eligible for the plan. That's one. And then regarding new residents, it says new residents of the state can enroll at a provider's office when they seek. Oh, that's the next one. We haven't gotten there yet. Is that right? Okay. Yes. Yeah, it's on the slide, but yeah, we haven't gotten there yet. But yeah, can we eliminate that, or why is that? Why are we talking about benefits in an eligibility straw proposal?
The only reason I included it is because you've talked about 2 different levels of benefits, and I figured eligibility for one level of benefits would differ from eligibility for the other level. However, we haven't talked about what those criteria would look like. I'm happy to omit that and let that live in the benefits proposal. That makes sense.
Yeah. Yeah, eligibility for benefits is different than eligibility to be on the plan. And what we're talking about here is who's eligible to be on the universal health plan. And then what level of benefits you get, I think, depends on a subset of eligibility criteria. And I think it would be better to leave it off, but I'm open to feedback on that.
Dr. Hemmings.
Hi, I think someone may have been asking this question, but I may not have heard the answer. Just curious, why was it necessary or recommended to separate out specifically include including incarcerated individuals versus just leaving regardless of income? Why
That
was
is,
it? Yeah, sorry.
that's an excellent question. There are federal statutes and state statutes that separate the two. And even in looking at international models, even Canadian statutes separate the two. So in a lot of Canadian provinces, all residents are eligible and incarcerated people are accepted from that. In the meetings leading up to discussions on eligibility, there was at least a couple of members who asked this question about incarcerated people, which is why I asked the question in the eligibility discussion, do you want to include these folks? So would you suggest a revision to this point to just leave it be and not mention incarcerated folks?
Because it already says all residents. So I'm just trying to understand, why does incarceration need to be qualified within the all residents? Because if it says all residents of Oregon, regardless of income, why would anyone assume that does not include incarcerated individuals if they are incarcerated within the state of Oregon? Are we not seeing incarcerated people as residents of Oregon? I mean, someone could be incarcerated here, but this is not necessarily their primary residence. Okay, I just answered my question. Okay,
Or if they're in a federal prison, aren't they in federal
right.
custody?
Yeah. Okay, thank you.
Jim?
So something that is a little bit confusing to me. What I'm hearing is, at least in some cases, it's not that incarcerated individuals don't have access to health care. It's whether or not they get included in this plan. Am I understanding that correctly?
Yeah,
I mean,
there is prison operated healthcare. Yeah.
From my point of view, I think for administrative and clinical simplicity, as I've said this before, I think it's keep them all in one plan is better, because at times they will be in this plan and at times they'll be in the prison plan, maybe. Ideally, they go back and forth. My grandson is a good example. So I like the idea of including them in the plan.
Okay, for the sake of time, I've noted down your points here. And I'm gonna ask if there's any objection to moving on to the next set of points. Okay. So the next set of points from the patient perspective is that people who are residing in Oregon at the time of transition will be automatically enrolled. This would be similar to Medicare enrollment at the age of 65, when you just get sent your card and you're enrolled automatically. New residents of the state can enroll at a provider's office when they seek services. Is this what you want to include in this proposal? Can I get a fist to 5 on how you're feeling about this set of points? I'm seeing some 2s and 4s. 2s, 4s, a 5, a 3. Okay, then I will pause and invite feedback from committee members. How can we make this better? Chair Diaz.
I just wonder if having it for the new residents enrolling at a provider's office as the only way is limiting and a barrier.
That is an excellent point. Eve.
I think about our desire to cover people who are undocumented. And I feel like we need some sort of a process beyond just an auto enrollment from people we already have documentation on, in order to assure greater coverage. Now, we have it to a certain extent in our HOP population with OHA, so that's helping us, but we're not 100% of the way there for sure.
Okay. Thank you. Mike.
So this is more of a semantics kind of comment, and it may not need to be anything, but we say all residents of Oregon in the patient perspective in the first one, and the second one says people residing in Oregon. And I don't know if that is the same definition within both, but I wonder if we want to clarify that to some degree, because residents of Oregon, I don't have the physical component really kind of there, and then people residing in Oregon. And I wonder if there's those individuals who may or may not physically be within. And I just want to make sure there's the same definition or maybe the same language or something that clarifies that meaning is the same for both.
Thank you for that. There is more discussion on residency definitions, but thank you for raising that point. Helen.
That I had a similar question. So, definition of residency.
Gabriel.
Yeah, my question just sort of dovetails a little bit on Debbie's. This bullet about they can enroll at a provider's office when they seek services, and I'm trying to think outside the bag of what are some other avenues by which someone might seek to enroll, and I don't have the answers, but I also wonder, like, if we're placing that burden on the providers' offices, like how streamlined is that? How messy is that at the front desk when people show up and need to enroll in a new insurance? Maybe there's nothing cleaner than that. Just brainstorming.
Thank you, Peter.
Yeah, just want to echo Gabe and Debbie's points about enrollment at the site of a provider's office. I think there's certainly some potential for incorporating this into the one system if folks are kind of signing up for other social programs. I think it makes sense to allow for enrollment either online or potentially at other government offices or other sites. So I think expanding that and being a little bit less restrictive there is a good point.
I appreciate those suggestions. Thank you. Tosh.
Yeah, I would echo similar sentiments. One of the ways you can reduce the cost of the health plan is to reduce administrative burden. And the steps should be simple enough to where a person can enroll anywhere, even if they're registering to vote, or even at a hospital, even like any kind of wherever we can get driver's license. Like the process should be very simple, and I don't want the administrative burden to fall on a provider's office or even like just at the hospital where they're seeking care.
I appreciate those points. Thank you. Tony.
Yeah, I appreciate all that's been already discussed. I guess I call in order just as if this is a purview of what we need to be focusing on. This seems like an operations consideration, and wondering if this is a specific area that we would hold us up here today on this. There are multiple ways that we do sign up for like OHP. It's not a singular effort. It does occur in my clinic office, but it's not the only way. So maybe just a consideration there.
I appreciate that. And it leads nicely into the next slide. Katie, if you'd move to the next one. So I noted in the draft that is supposed to be torn apart because it's not fully fleshed out yet, that the committee hasn't reached consensus on residents providing proof of address. The breakout group asked me to look more deeply into the public school district model of residency requirements because it seemed to be a good balance of like proof and flexibility. What I found is that Oregon statutes are not very clear on residency definitions for schools. They're much more clear for voters, driver licenses, and OHP and other social programs. My question to the committee would be, do you want to define resident in this committee? Or maybe ask operations to weigh in? but for now, I'll stop at that first question. Fist to 5, does this committee want to get into residency definitions? Being a 4, because we can dive in, and I did submit a 0, 2, 3, 2, 3. Okay, okay, so I did provide a draft definitions document on this issue, but given the time constraints that we have into today's discussion, is there any objection to moving on from residency requirements today and maybe having me do a little more digging offline? No objection there. Okay, I appreciate that very much. I'm about halfway through my time, so fantastic. So then the next point we have is about people who work in Oregon but live outside the state. I include a recommendation that says people who physically work in Oregon but live outside of the state within a specified distance of the state boundary and contribute to the plan via taxes will be eligible to enroll in the plan. So these are people that live close enough to access services, and these are people who are physically here and contribute via taxes. Is it the intent of this committee to allow these people to enroll in the plan? Can I get a fist to 5? Some 4s and 5s. 4s and 5s, fantastic. 4s and 5s. I know it is a complicated issue, but if that's the intent of this committee, we can look into how other countries handle that. Chair Belanca.
So I'm not sure I understand this. Are you saying they have to full-time come to work in Oregon? Like they can't be remote workers. They can't live in California and remote work for an Oregon company. Is the physically work in Oregon, is that phrase meant to capture only people who physically show up to work in the state?
Yes, there are a couple more categories on the next slide for remote workers, I believe, but this specifically is folks who physically work in the state.
Okay, and then hang on, please. Let me go back. I want to be really careful here because the only way those people would be contributing to the plan via taxes is through a payroll tax. And what that means is that this health plan is now bound to employment. And one of the goals of the board is to decouple health insurance from employment. And so if we are in agreement with this version of eligibility, then we're saying that your eligibility for this plan depends on you being employed by an Oregon employer. And I would really caution us against that. I disagree with this. I don't think we should include people who don't reside in Oregon. If they're getting their health insurance through their employer, I think there are other strategies to keep their insurance through the marketplace or through subsidies for them to get on the employer's plan. The employer's going to have probably not one employee who lives out of state, but probably many. And I think there are other ways for them to not lose insurance without covering them on this plan. But if they don't reside in Oregon, I don't think they should be covered. We really want to decouple it from employment and just link it to residency.
Thank you for raising those points, Mike.
So my comment kind of dovetails a little off of Helen's, and it's more along the lines of taxes, just that's rather broad. And I don't know what various tax revenue streams there are. I mean, it's possible that somebody that doesn't live in Oregon but comes to work ends up paying a lot less or a fractional amount of taxes, but they still get eligibility for it. So if we're going to have taxes in there, I would feel more comfortable if I understood the streams and the amount, where they're coming from and what they're contributing to it, because we may be subsidizing somebody who's, we're living out of state and we're end up having to foot the bill for a lot of that or we could use that money for our current residents as we're defining them.
Okay, thank you. Betsy.
So I want to thank you, Dr. Belanca, for flagging that issue. I think I'm not settled yet on to me, decoupling insurance from employment means that I'm not getting it from my specific employer, but doesn't necessarily mean that I'm not using a payroll tax. I'm not paying via payroll tax or contributing via payroll tax for that work. think inherent in our assumption is that there will be some people who will receive benefits under this plan without having contributed to it, at least not continuously, right? Or that in whatever way we determine, which is, I think is the finance work group's kind of purview, which is where this gets really fuzzy for me. But I would not want a system in which someone who is unemployed did not get health insurance through this plan. And that, I don't think we're proposing that, but I do think that we do have to have a mechanism to understand whether someone deserves their coverage here versus through some other means because they don't live here. And that I think is kind of tricky. If we are attached to the idea of a payroll tax being the primary funding mechanism, then I don't think we can completely divorce this from the concept of employment.
Right. Yeah. No, yeah. Those are excellent points. I'm guessing at this point, but I think there is likely to be a payroll tax. I don't think it's going to be the majority of funding. I think the majority of funding is going to come from an income tax. So these folks would not be paying an income tax. They would only be paying like a small fraction through a payroll tax of what everyone else in Oregon is paying. And I would say that, like, if you live in Vancouver and don't work for an Oregon company, are you eligible for this plan? Clearly not. If you live in Vancouver and work for an Oregon company, then you are eligible. But then the fact that you're eligible is just completely dependent on who you work for. And if you change jobs, then you lose your, right? You know what I mean? Like, so it does, you're right. The decoupling part, made sense, but their fact of being eligible depends on them continuing to be employed by an Oregon company. And that's the part we're trying to get away from, that they shouldn't have to depend on employment for their healthcare coverage.
It is messy and it does overlap significantly with the work of the Finance and Revenue Committee. I asked my sister about this. She's a tax professional. She works 1 day a week in Portland, but lives in Vancouver. She pays payroll taxes in Washington. She only pays income taxes in Oregon for the about 50 days a year that she's actually here. So it's extremely complicated. It's not cut and dry. I appreciate the dialogue, Jim.
The people who use the word messy and complex, that's probably about as accurate as we're going to get on this issue. So coming from the administrator of an employer-based plan, I tend to have that bias. And I think of an employer who is currently providing healthcare benefits for all of their employees, including those who live out of state. And now all of a sudden, a portion of their workforce doesn't have access to health insurance. I'm not saying one way or the other which way we should go, but I think there's some messy components to this, it's one of the challenges of trying to develop a state-based plan inside of the United States. But I think we ought to keep that in mind. I mean, I personally support this idea, but it's not easy, and I definitely want to move away from reliant on employment-based insurance. I think that's a worthy goal.
So just to float an idea, if we make up numbers and say that we have an employer who currently pays $10,000 per employee per year in premiums to cover all of their employees for health insurance, and suddenly the universal health plan is in place, then 80% of their employees are going to be covered on the universal health plan, and the employer is relieved of that duty to pay $10,000 each for those 80% of employees. They don't have to pay that anymore. There will be a payroll tax, which is different, and it'll go to the state. That 80% of people, get translated into a payroll tax, go to our trust. And then for the 20% of people who live out of state, the employer, while they may not be able to purchase a plan, they wouldn't be able to purchase a plan to cover those employees, they could subsidize those employees on the marketplace. They could give them $10,000 effectively, $10,000 each per year to purchase insurance through the ACA marketplace, right? So like you could the employer could still subsidize their health insurance as they do now, and make sure they don't go without coverage. It would just be through a different mechanism, right? So it's just there are ways to address it and have people. I know that the intent here is to have people not lose their insurance just because they live out of state, and I fully support that. But I think there are ways that you could do that without.
I'm not so sure that subsidy of an ACA marketplace is actually legal. You might want to have your people look into that, but
I know
it didn't used to be. Hmm?
I'd be happy to look into it and bring back a few more options next time. But for now, Debbie.
I just have more of a question, but when individuals need to apply for unemployment benefits, does that go through the state that they're residing in, or the resident of, or the state that their employer is in? Because I was under the impression it was through the state that the employer was in, and I'm just curious about that.
I do not know.
No worries.
But I'm happy to find out. Jamie.
I'm just wanting us to make sure we're thinking about how this connects to the previous slide when we're trying to make it really easy for people to enroll. And then we ask them to sort out something really complex like this at enrollment. Those two ideas are not compatible with each other. And so if we decide to put in something about folks who are physically working in Oregon but live outside the state, then their enrollment probably has to go in somewhat of a different role than to ask the PSR at my front desk to figure it out on her own, depending on how much they pay taxes.
Yeah.
Thank you. Dr. Hemmings.
Okay, so I'm trying to understand this. I'm an employer. I have employees who live outside of the state of Oregon. I pay for their insurance. So under this plan, what we're saying is that I would not have that option to continue paying for their health insurance, because the only option that I would have as an employer is for them to be part of this universal health plan. Is that correct? I won't have the commercial option as an employer as well. I thought we were going to have a universal plan as well as I think this discussion happened a few months ago. Universal, as an employer, my only option to ensure my employees will be through the universal plan.
Well,
I won't have the option of the commercial insurances that I currently utilize. Is that what we're saying?
Yeah, it wouldn't be your obligation as an employer to cover your employees.
Right, they would be automatically, well, not automatically, but covered under the universal plan, so I would no longer have to do that.
Exactly.
But my employees who live outside of the state, I would have to do something like maybe, some kind of, and companies do this all the time, contribution towards their health coverage for them to have insurance elsewhere.
Exactly. That's what I was getting at. And Jim was, right and correct. Like, I don't know if it's legal to do something, but
it may not be through the health,
maybe not through the insurance exchange.
Right, but companies do a
like a stipend for health insurance, like some way that they could still contribute to those employees' coverage in their home state. I think there are ways to do it. I don't know what the options are, but but you're right. There would be no commercial plan would operate in Oregon that offered the same benefits as the universal health plan. That would be one of the stipulations. So there wouldn't be a commercial option in state. It would have to be something in their state.
My other question was, is there going to be a time frame regarding residency? So if someone relocated here to the state of Oregon, how does one establish residency? Is there, because I'm from New York, and I remember that there was a time frame, I don't remember how long it was, before you could apply for benefits in the state. Does that exist? Is that going to exist here when we talk about proof of residency?
As far as I know, that's currently undecided, but in our international comparisons, we'll talk about how some different countries approach that. So there are a couple different ways to answer that question. I see you both, Betsy and Tosh. I do want to mention that the next slide talks about an idea that I think Tony brought up in the last meeting, which is a tax credit for those non-resident employees who won't be able to access Oregon healthcare providers. But for now, Betsy.
So I run a very teeny tiny organization for employees, and no one would write us health insurance. So I looked into it, and there are in fact plans where you can contribute to, you can give an employee a certain stipend of money that they can then handle as pre-tax to use to buy health insurance. That is legal, and you have to work with a broker to sort of set the plan up. But that's a thing. The other thing is really just a funky little operational thing, which is that there are two people in the waiting room. Or should we be letting people in, or I've noticed that one of them's been there pretty much the whole meeting.
Thank you, Betsy. They just showed up on my screen. I'm letting them in now. Thank you for
sharing that experience, Betsy. Very helpful. Tosh.
So my question is probably the fact that we are saying 40% of the people who for an employer, if they don't live in this state, then they will not qualify for insurance. So part of my understanding, and it could be wrong, is that employers enjoy, or they get the group coverage. When they get a big group, they get a group discount, right? So when half of those people are covering out because the state plan will cover for them, the half of the people who live in a different state, would it become more expensive for the employer to provide healthcare for these people? And if that's the case, will we have a split amongst employers who will not buy into this plan because we are creating this sort of situation? Because at the end of the day, we want buy-in from everyone.
I think what we were talking about, Tosh, is that they wouldn't be purchasing group insurance anymore. Like, they get the discount because they're purchasing group insurance, which if they're based in Oregon, presumably that insurance is based in Oregon. And so that would go away. And instead of purchasing group insurance and getting that bulk discount, they would give stipends to individual employees who work out of state to purchase health insurance on their own. And they wouldn't be purchasing a group coverage. So you're right. Of course, they would lose that market power, but it wouldn't be relevant because they would just be giving stipends, whatever they could afford to give for stipends for their employees.
Is there any objection to moving on to the next slide? We've only got a few minutes left in my allotted time. The next one explores.
Danielle, if you want to go, sorry to interrupt. If you want to, since we did take the break early, if you want to go take the full next, like, whatever the 17-minute, like, go to the next thing. I mean, that's fine. You don't have to stay within the 40-minute timeline.
I appreciate that. Thank you. Katie, will you take us to the next slide, please? Okay, so this is an idea that was floated last time. There was not consensus among the committee. We got a lot of mixed reactions. So I have said the committee is considering a tax credit for workers who live out of state and contribute to the plan via taxes. So that would be if the Finance and Revenue Committee decides on a payroll tax, but they live beyond a certain distance from the state boundary. I suggested 60 miles. I meant to take that out. So sorry. And thus don't have reasonable access to services. So this is for the folks who live outside of Oregon, work for an Oregon employer, but are so far away that they cannot see doctors in Oregon. There was an idea floated of a tax credit for those employees if there's a payroll tax to make sure that they are getting their money back to purchase insurance in a different state. How does the committee feel about this idea? Fist to 5. Do you want to talk about it? I'm seeing a 2. Lots of possible confusion. 3s. Some 3s, a couple 4s. 2s, 3s. Okay. So no 5s, but no 0s. That seems great. Helen.
Is it possible that, I don't know the law around this, can people be, can they be exempt from the payroll tax? Like if they're in this situation and they live far away, could the employer have a payroll tax only on the employees that live in Oregon? And for their employees that don't live in Oregon, they wouldn't be subject to the tax? I don't know.
That is an excellent question.
I think that would be way easier than giving a tax credit.
As an employer myself, there are certain taxes that my employees who are not in the state of Oregon are exempt from. And that's built into my payroll processes set in around employer versus employee payroll taxes. So there is a way to do it. And it's legal, obviously.
That seems simpler, doesn't it?
I appreciate you both sharing those perspectives because obviously this is something that I do not have experience with. So thank you.
There's a local transportation taxes that are like transit taxes that are only assessed to people who live in
That's
the
an
region.
example of it. Yep. The metro tax. Yep. Yep.
Jim.
So a couple of thoughts here. Again, I'm thinking of it from the employer perspective. The employer wants to provide healthcare coverage for their employees. A tax credit might not be enough for that employee to buy insurance. Could there be a mechanism to help the employer subsidize coverage for non-residents? I just throw that out there. It's not necessarily something I automatically advocate, but just trying to keep in mind the perspective of employers who want to provide health insurance for their employees.
Thank you. Betsy.
Yeah, I just had the thought occur to me in this conversation that are we assuming that children will be individually insured as well? Because, for example, my husband participates in OEB and all of us are insured under his participation in OEB. In this construct, would my children be individually covered people as Oregonians, or would they be my dependent? And if that's the case, could I be my husband's dependent if I worked, like, we can't get away from the employer construct. But it just occurred to me to ask that question.
I think everybody's individual people. I think partners and children are all counted as individual residents. There's no age limit on who makes a resident. Babies would be insured from the moment they're born as individual Oregon residents, right? So it's not a family, it's not dependent on that, right?
How do you then handle children who go off to college in another state?
It looks like that's our next thing to discuss here.
Oh, sorry.
Actually, it's not.
It's not?
No, because it's the other way around.
Oh, sorry, you're right, it's the other way around, sorry. Yeah. Oh yeah, did that come up, the children who leave Oregon to go to college?
Yes, but we treated them the same as Oregon residents who are traveling. So did not treat them as dependents, treated them as individuals. Happy to explore that though. Angela.
I just wanted to talk through this scenario. Yeah, we are on the border. We're in FQHC on the border. We have clinics in Washington and Oregon, and it is a porous border. There's folks that, right, see providers on the Washington side that live in Oregon and vice versa. So I was just trying to play this out of what it would look like for patients. And there's actually limited access for dental on the other side in Washington. So a lot of folks come to Oregon for that. And I don't know if we've sorted dental quite yet, but so yeah, would it be more of a definite line and like you're insured in Oregon, you have to be seen in Oregon? Or yeah, could you go and be seen at a Washington clinic then? And then we would pay them as well. I'm just trying to play this out.
That is a really good question. The breakout group last time discussed that if out-of-state providers have prior authorization from an in-state provider, they floated the idea of following current Oregon rules for providers who provide fee-for-service services on OHP So those out-of-state providers can enroll with OHA to deliver services to OHP members. That's the
Okay.
extent of my knowledge on that issue.
Okay, yeah, I missed the last meeting, so thank you for some of that.
Yeah, but happy to clarify in the next version of this draft. Tony.
Yeah, we're getting into the weeds here, and some really tough decisions. And I see us at some standstills with this. I was kind of curious, just as we look at these, is the intention, Chair Diaz or with Danielle, to bring these back with more data? I think about this in these isolated areas and the totality of what are the numbers we're looking at. This is not going to be perfect. It's not going to capture every single scenario with a win for every single one of these. There's going to be trade-offs with this decision making. And I think what would be fruitful in thinking the next steps, also the relevance of the financing of what we look like, what we can pay for in some of those contexts. So I guess my question is, are we making decisions today on this, or is our intentions to bring these back with more data, right? Okay. The other, piece of this is the data with regard to how many people are we talking about, and looking at those numbers, I think would be really helpful as we make those trade-offs.
Thank you for that. Jim.
I think, as we discussed the last time, most colleges require that their students be insured, and they frequently require that they contribute if they cannot demonstrate, that they have insurance otherwise, that they pay to participate in the university program. My question would be, how much are what's the share that universities are currently paying now for that coverage? That'd probably be helpful to answer the second part of that paragraph.
That's an excellent question. I'm just going to read the second part out loud so we're all on the same page about non-resident students. What we have so far is non-resident students who are enrolled in Oregon universities that contribute to the plan will also be eligible for universal benefits. The committee plans to consider whether these universities can contribute to the plan on behalf of these students. So like you said, Jim, universities do collect contributions from their students for their student health insurance plans. The idea was floated last time. How does the state capture those contributions from universities? Should we? Is that a tax? And this is something that I would pose to committee members to get a little more feedback on that idea. And I'm not doing a fist to five, but please feel free to raise your hand or just weigh in.
I mean, it makes sense to me to do that because effectively it's an insurance company, right? And so instead of collecting premiums as a university health insurance, those dollars would go to the plan. Yeah, I mean, it makes sense to me to do that. And just as a broad reminder with the last couple of comments, what we're doing here is coming up with a straw proposal and saying this is directionally where we want to go. This is directionally what we think is right. And then it's going to involve a lot of calculations and numbers and analysis by our financial consultants to kind of work out what that means. But they want to know from us, what is the plan? Who's covered? What's covered? And then we'll work out the numbers for you. So we're just trying to make a statement about who we think should be covered, and because that'll affect what numbers they use. So yeah, just keeping that in mind.
Thank you for that. And yes, and we'll send this proposal off to the board and see what the board has to say about it as well. Peter.
Yeah, I just am wondering what might qualify a non-resident student as one who does contribute to the plan versus one that doesn't, because it seems like it's specifically called out there that non-resident students enrolled in Oregon universities that contribute to the plan will also be eligible. Just wondering, what the circumstances would be that would kind of bring them to either contribute or not contribute.
Thank you for that question. Okay, we've only got a few more minutes. With your permission, I'd like to move on to the next slide. We won't get through all the questions I have. Yes.
Yeah, Dana, I agree. Probably just strike that phrase. Just non-resident students enrolled in Oregon universities will be eligible for benefits. Just strike that phrase because I think it is kind of confusing.
I absolutely can do that. Okay. Can we please move on to the next slide, Katie? This is my last slide on the patient perspective. I have 2 additional slides, one on the provider perspective and one on the payer perspective, and 5 more minutes until our next agenda item. I would encourage members to read through the draft straw proposal. Again, you're supposed to tear it apart. It's not going to be perfect. This slide is on temporary visitors and Oregon residents while they are traveling. Do you want to spend some time on that, or would you rather move on to the provider perspective and see how you feel about those? So, fist to 5, a fist we stay here, and 5, let's go ahead and move on. Fist we stay here, 5 we move on. Oh, okay. A good split among fist we stay here. Okay, let's stay here. So starting with the first one. Temporary visitors to Oregon, including tourists, will not be eligible for the plan. They may seek emergency care. The plan will reimburse providers directly. Then the plan will bill the visitor's insurance. Is this what you want to recommend? And Eve, I'll start with you.
I don't think it's reasonable for us to assume that temporary visitors would only need to seek emergency care. You know, someone who's here for a month visiting family might need routine care to be done while they're here, and for us to not permit that to happen could be a hardship and could actually force them into our emergency system unnecessarily.
That is an excellent point. Thank you. Debbie, Chair Diaz.
Thank you. That's a good point, Eve. The only thing I want to say as we get into these next is just to be cautious with some of the reimbursement discussion, just because we haven't fully taken that up. So I don't want to get too far into the weeds on something that's a little premature potentially.
Thank you. Jamie.
I also just want to call out that there are medical tourists that are going to come because Oregon might provide gender affirming care that their states don't provide, or access to reproductive services that their state of residence does not provide. And we should probably think about that in this group because it's complex, but I think Oregon's commitment to equity demands that we give consideration to those individuals.
Thank you for that. There's we're working on a brief section of that in the research document. I appreciate you raising that. My last couple points on this slide are about Oregon residents while they're traveling. And I'll read them to you and cut off when we can. When Oregon residents travel to other states and experience emergencies, the plan will directly reimburse those out-of-state providers for emergency services. And then I noted that the committee has not reached consensus on whether the plan will reimburse out-of-state providers for non-emergency services without prior authorization. Jim.
So an issue that I raised last month is not addressed here at all, and that is I am presuming that there are a group of people who get pensions from the state of Oregon or elsewhere who think they have entitled to benefits while they're retired. And will those benefits continue if they relocate to a sunnier state, for example? I think that's more than a couple of people, probably. I think getting some numbers from the large state and health pension plans would probably be helpful in that respect.
Thank you. Any additional comments before we move on to the next agenda item? Chair Diaz.
I'm just wondering if it would be something that would be helpful for you to have some kind of work group work with you on some of this rather than just taking it all on and coming in, just because there's still much to cover. Just throwing that out there if that's something you'd be amenable to, if that'd be helpful. Or
that's an excellent idea. I will go ahead and check with Jessica and other OHA staff and probably connect with you offline if that's okay.
Yeah, and members of the committee, like just how we had some work groups for behavioral health and long-term services and supports, just I think the more people thinking about this, the more ideas and the more scenarios that'll come up.
Thank you. All right, Jamie, last comment.
Yeah, just another quick comment about another group of individuals that we may inadvertently exclude, or are agricultural workers who may reside in several different states in the region as they sort of follow harvest or follow planting around, and making sure that whatever decisions we come to, we're not inadvertently excluding them on the basis of that they don't have a permanent address. So again, like just try, if we make it super, super simple and we ask the question, do you live here in Oregon? And somebody says, yes, yes, I do.
Okay, thank you. Thank you all so much for allowing me to have this discussion with you. It is a privilege as always. And I will hand it back to the chair.
All right, so can I just get maybe a show of hands if there is anybody who would potentially be interested in being part of a eligibility work group in the interim before the next meeting, just to gauge interest so we can follow up. I see Jim's hand, Eve, Tosh. I'm not the best at clicking through all this.
Tony,
And Tony, okay.
did we
All
miss
right.
anyone?
Yeah, please speak up if we missed you.
I want to call out Dr. Osborne was sort of giving you a half yes. And I would say I'm sort of in the same place. Like ideation would be hard, but I could react. So if
Yeah. And I will throw that out with the caveat of I will be also asking for a potential work group for provider reimbursement. So if you just depending on thinking about bandwidth and where you have the energy to spend. But thank you all. All right, so it sounds like April, we will be revisiting this discussion as well, but hoping to get moving on also into provider reimbursement, which will be a big topic. So we will get an overview of the task force recommendations, but really want to start thinking about what additional information we need to have the conversations, and who of the committee would be willing to start taking on some of those conversations, much how we did with the interval work with behavioral health and long-term support.
Should we just start with the second bullet of like asking the committee what information we need, and then
Yes.
if there are people, yeah. So I mean, I would really be interested in having a discussion about what do we know about the impact of value-based payment strategies in terms of cost savings, in terms of improving quality of care, which value-based, and there are many, which value-based payment strategies are worth preserving and which ones are not. And then the impact of different payment strategies on primary care reimbursement versus specialty reimbursement. I think those are some of the first questions that I would have. There was just a really good article in JAMA and a lot of response to it about this topic.
Thank you, Helen. Eve?
To me, value-based reimbursement is only really truly value-based if you're looking at kind of a total cost of care metric as your outcome. So the way that Medicare has done value-based payment is force providers to figure out a bazillion different codes and apply as many codes to someone as possible to make them look sick. And then you get paid based on how sick you make your patient look through documentation. And if you're not good at documentation, at knowing all those codes, then you get paid less, and it may not, and it doesn't actually make the patient.
Yeah, right. That's what I mean. Like,
So
how it runs in different settings and what's of value and what's not.
So I think we have found that capitation works in our FQHC. That would be a big leap for a lot of primary care providers. And potentially we would want to look at different reimbursement models for different models of care, which goes back to needing to have a separate conversation about how these kind of comprehensive medical homes, the FQHC and CCBHC models, fit into the system. I think they often work better under a capitated model because you're utilizing a whole bunch of support staff in order to wrap care around someone. And fee for service is often still the preferred method in much of the private sector, where there's not as big a care team and it's really focused on getting folks in and out the door. So I don't know that we could successfully push the provider market to one type of reimbursement methodology with this transition. I think that would throw a lot of things on its head. But looking more at how to target this to different types of providers. And I'll be quiet because there's a lot of folks who are interested in talking.
Thank you, Eve. Gabe?
I'll be brief. I think if we are going to be talking about value-based care, I would love to see any data there is out there about how value-based care structures impact provider and staff burnout. I think that's foundationally important to our workforce.
Thank you for that. Rob?
Yeah, I would just say that, you know, on the capitation-based model, like a lot of what I've seen working in Medicare Advantage and other things is, you know, very much as it was described as far as, you know, coding for revenue and things like this, but it's also not really possible to make a capitation payment system work without some kind of risk adjustment to the payments. And it's that like risk adjustment that creates some incentive for, say, coding that then can, you know, come to dominate. So, and also there's an issue of, you know, thinking about practices that are too small, you know, generally speaking, too small to take that level of risk, you know, capitated risk for the populations that they serve, often are, you know, in communities where there just aren't that many providers, you know, also because, say, they're rural and populations are small, that that exploring some kind of cost-based payment similar to, you know, what Medicare does with, for example, critical access hospitals and FQHCs to an extent and other things. Worth considering.
All right. And then just as a point of clarification, this is more kind of questions that we want to bring up that we can have our staff do some interval research and maybe have a work group also do some work on as well. So, and then we'll have a robust discussion, probably several discussions over several meetings. Jim.
So I'm very sympathetic to the notion of upcoding to game the quality metrics. But I'm also a resident of Maryland, where we have capitated hospital reimbursement, and I would be willing to contribute information in that regard. In that area, I was on one of their work groups for a while. So, and I also wanted to say, you might want to look at some of the staff model HMOs and see how they incentivize quality or manage quality in their institutions, and whether that can serve as a model for the Oregon Health Plan.
Thank you, Jim. Tony?
Yeah, really appreciate the commentary with regard to the trade-offs that we've had with value-based care and with the impact that has on the workforce. I think that's a really important point for attention. I think as a starting point also, as far as just prior approaches to this question with Senate Bill 770 and with 1089, is that just this being predicated that it would maintain dollars, that the current spending level is for provider reimbursement, that the idea would not be to decrease any level of that funding in order, you know, basically for an understanding that for buy-in from the stakeholders for this plan. I think an investigation of global budgets, particularly for hospitals, and how other nations have done this and how they've been able to decrease the increase in spending that we have, that's one tool that has been outlined. So I'd just be curious to learn from other countries how they structure that.
And Maryland, by the way.
Well, I was just going to get to that, Jim, is that, Maryland since the 70s has done this very well, and particularly in the last, 2 decades. And I think that there's a great deal of learning as far as one of the bigger places we spend money are in hospital settings. And Maryland has been really instrumental in doing that. So I'd like to hear more about how we might leverage that here.
Thank you, Tony. I'll add on, I'm personally interested in incentivization for primary care and behavioral health. I think that would be an important thing to consider with reimbursement structure. Rob.
Yeah, I just wanted to say that, Maryland is in some sense a capitated model, but those capitation payments for the providers in Maryland, as I understand it, are based on costs. That providers submit their cost reports every year, and then the state crunches the numbers and is like, here's what we're gonna pay you next year per admit, per visit, or whatever, and then it's all reconciled at the end of the year based on what actual costs were for providing services plus whatever the 1 or 2%, or I don't know exactly, but so it's not a purely like prospective capitation based model. It's all reconciled as far as I understand based on actual cost, which is in some ways already a risk adjustment mechanism, right? You're just finding out, what resources did you actually use to provide this care, and then here's the money for what you used plus whatever else we've agreed on. That's all. Just wanted to add.
Thank you, Rob. Jamie.
Thank you for prioritizing primary and behavioral. I think the other piece to look at that I would like information about is, are there particular critical shortages? And might we consider some differential payment structures to ameliorate the critical shortages that we're encountering in the state? You can ask any family doctor what those are, and we can tell you in a breath. But I think data would also be great.
Thank you, Jamie. Jim?
So if I can correct the record on Maryland, the way the Maryland hospital reimbursement works is, and it is indeed complicated, but in its simplest form, they basically say to all the hospitals in Maryland, you spent $18 billion last year, we're going to give you a 2% increase based on population and inflation. And then the battle gets over who gets what and how it gets allocated and stuff. But at the most global level, it is not global budgeting. It is sort of global budgeting at hospital, but it's global budgeting at the state level.
Yeah, we will get into discussion next time. I definitely just want to make sure we ask the questions and get the information we need. Mike.
Thanks, Danielle. So 2 comments. One that goes off of Jamie's, which is, I sort of anyway, I'd love to know which areas we can provide maybe higher reimbursement that's going to result in greater savings down the road and or better outcomes. I know that goes to kind of the VBP discussion, but I'd love to understand if we invest money in certain provider types and we get an ROI on it, that would be helpful. I think something else that I'd love to know, which I don't think we'll be able to find, is just what are providers getting now with the various health plans? Like, is it 100% of CMS? Is it 120%? Like, I don't know, because I can say right now I want to pay a provider X and that sounds really good. And then Tony's like, I'm quitting because I make no money now. I don't have a good idea or sense of what that looks like, because a slight change in the payer mix in terms of the overall reimbursement can have a huge effect because there's set costs with every type of provider. And if you have one small margin, you might think it's a big deal, but the margin component is a much bigger component of what you're eating into. So I just want to be mindful of that too.
Thank you, Mike. Eve?
Yeah, I agree. And And I think it's important that providers don't lose the ability to make the income that they're making today, at least. So as we talk about other areas that we want to invest in, and I agree, primary care and behavioral health providers need to be compensated more than they are today. That those dollars, I think, need to come from the savings that we're getting from administrative costs in the plan, and we need to maintain the incomes of the specialists that we have, because whatever we all think about what certain specialists or subspecialists make, that is ultimately what they make. And we risk them fleeing our state if we rebalance based on, taking from one specialist and sending it to a different type of physician. So I just want to make sure that we don't lose access to specialty care in the process.
So what I'm hearing is we also need to know what providers are being reimbursed currently in our current system, if you will. All right, Tosh.
Similar to what everyone has been saying, I think the goal here is to make sure that to prevent the main areas where costs go up, right? Like hospitalization goes up. One of the ways we can prevent hospitalization in many instances is to like give patients proper preventative care, give them access to primary care, to mental health specialists, to even like specialists too, to prevent big dollar investments, hospitalizations. I think the goal here could be a mix of fee-for-service and value-based service. Like, can we come up with a hybrid model where patients' hospitalizations are prevented in the long run? Another thing, like maybe as we're focusing on this, the main expense of a healthcare system is probably not through providers or how much a hospital is billing. There are like middleman services too that incrementally increase the healthcare system's expenses. So if we are moving towards a universal health model, there will be opportunities to cut out this middleman and bring those savings to the plan where we can ultimately distribute it to the providers. But I think like we need to have a more global approach as to like not limiting the conversation to how much we are paying the provider, but what is the end goal? It's to like cut out expenses so that the providers who are providing the service can be ultimately compensated.
Thank you, Tosh. Those are good points. Is there a specific like information requests for staff to help get to that?
Is the question for me?
Yeah.
Yeah. Okay. So when I talk about middleman services, I talk about like PBMs, right? Those are like one of the bigger ways healthcare expenses go up. I talk about GPOs that hospital systems utilizes, and it's in GPOs are a way for people who don't know what GPOs are, group purchasing organizations, but basically manufacturers have to pay a fee to be in their catalog, and the hospitals get to like choose them. But essentially what happens is that the hospitals don't get to know how much those manufacturers are paying the GPOs to partake in this catalog system. And then the savings that GPOs save the hospitals do not know how much they're saving. So it's a middleman service essentially, but when you have a universal health plan, in many ways, PBMs will be either eliminated or those services will be reduced significantly, and so will be GPOs. They increase the cost of the healthcare system, but we can essentially think about like how those middleman services, if we eradicate them, then how will those savings come to the health plan and ultimately be distributed to like providers and hospitals?
Okay.
So that could be a research option.
Okay. Thank you, Tosh. Betsy.
So a couple of concrete things I think that would be helpful to know. I don't know if they're achievable, but I'm going to throw them out there. I would want to know whether the state can accurately risk adjust for the entire population, et cetera, essentially, so that they could say, Betsy Boyd Flynn is a 52-year-old woman. She's had 2 kids, blah, 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 blah. This is her risk score, so that a clinic doesn't have to do it, right? And could we get to a point where, because part of the problem with value-based payment, as someone alluded to, is that very small clinics that do not have the technical infrastructure, by which I mean that the actuarial expertise and or the software to analyze how much their patients cost, have a very hard time entering intelligently into value-based payment contracts that bear any risk at all, because they don't know whether they're going to end up with more or less. And so any of the upfront payments they get are harder to invest because they don't know if they're going to have to give them back. Single payer gets rid of that, right? Gets rid of a lot of that, but the need to risk adjust won't go away, because there are different pockets of populations who have higher healthcare needs, and we wouldn't want to, we're not trying to make sure that everything is absolutely equal for everybody. The other thing I'd be curious about is whether we have actuaries or economists that can give us a dollar figure for how much administrative burden is going to be sucked out of this system. Can we put a dollar value on how much less prior authorization will be taking up time, how much less claims appeals will be taking up time and money, how many, how much? I think you ought to try to put a dollar amount on the pain and suffering and hassle for patients driving back and forth to the pharmacy when the drug's not covered. Like, these are the places where I feel like the fat is in the system that we should be redistributing. And so in that respect, I want to sort of +1 what Eve and Tash said, that it's not about paying a cardiologist less, though I think that it's at least possible that many subspecialists would tell you that they are so overwhelmed with low acuity cases, and low acuity cases are showing up in their offices because they can't get into primary care, that they wouldn't mind maybe making a little bit less if the people they were seeing really needed to be there. I haven't had that conversation, but I think it's one we ought to have as a state.
Thank you, Betsy. And Jim?
So I've been administering a health plan for 30 some years. And first off, I would take issue with the PBMs, but that's a separate discussion. I think the big waste in the system results from the siloization of healthcare and the lack of integration. I think that it's one of the reasons why I think the staff model is worth looking into. There's a lot of very good points that are raised here. And so I often, we have about half our people are in Kaiser, which is a staff model HMO. And one of the things I say frequently is we never, ever hear a complaint from Kaiser people that their doctor prescribed a medication that's not on the formulary. Why? Because the Kaiser docs know the formulary. In the state of Oregon, presumably you will have one formulary and the doctors will know it. Same thing with prior authorization criteria. When you are treating Medicare, doctors who treat Medicare patients know Medicare's criteria for cataract surgery or for whatever it is. They know those things. So there will be less need for prior authorization because you're not dealing with a gazillion different prior authorization criteria. So I think
I just want to make sure we're not getting too deep into discussion, because we're going to have time for discussion. But is there a specific ask for staff that would be
I would
to bring to the meeting?
I would say take a closer look at the staff model HMOs that exist in Oregon and figure out how they incentivize quality, how they manage reimbursement. I think that's a model worth looking at.
Thank you, Jim. Okay, and I just want to be mindful of time. So Jamie, I'll have you be our last comment.
Thank you. There was a comment about risk scores. Check into that with OHA and Care Oregon in particular. We've been working on risk scores with them, and it's all automated in our EHR, and it's being validated with actuarials. So I think that is within reach, and it's not so complicatedly dependent on HCC coding as CMS is. So I think that's actually within reach. And then just offering a resource when you're asking about where to invest in order to find savings, check out what the Graham Center has. They have a lot of really good information about cost and savings and how investment in primary care can result in that. So that's a good resource if you're looking for places to answer your questions.
Thank you, Jamie. And any final asks for staff? And also, this is something, if something comes to your mind after this meeting or you have a chance to sit with it, you can email as well if there are research points that would be helpful for furthering this discussion next meeting. And on that note, any committee members wanting to take on this work group and help kind of flesh out some of these ideas?
I'll raise my hand again, but
All right. Not seeing any hands. Oh, Rob and Jamie. Thank you. All right. I think that's as far as I'm seeing. Okay.
Can we
And
nominate
Jim.
people?
You can nominate anyone you want, whether they'll accept. It's another thing. Tony?
I'll jump in on this one. Take me off on the other one.
Okay.
That's who I was going to nominate.
You felt it coming.
I felt the presence of it. Actually, I'm interested in it.
Thank you. All right. We have just a short amount of time before just a few minutes before we get into public comment, which we do have 2 individuals giving public comment. But any kind of reflections, feedback? Oh, I see 2 hands already. Tosh?
I was just gonna say, can I be included in the second group and be taken off the first group? I feel like there are better people to decide who's eligible and who's not.
Sounds good. Thank you. And Eve?
For a future agenda, I would like for us to talk about ambulance services and coverage. Probably under PEB, it's not covered very well, and the ambulance system is in trouble in our state. So I think we need to look at how that happens.
Thank you, Eve. Peter?
Yeah, just wanted to volunteer since it looks like a few folks are hopping off eligibility onto provider reimbursement. I'd be happy to sub in for eligibility.
Thank you, Peter. I appreciate that.
Sure.
Tosh?
On the ambulance stuff, can we also include air flight?
Yeah, transportation discussion, because yeah, we would. Yeah.
Gonna need a separate transportation discussion.
Yeah.
All right. Anything else? And that could be future, well, not getting too far into the weeds, but future topics or anything that was discussed that we didn't get a chance to hear your voice on. Now's the time.
Was telehealth versus in-person already discussed as relates to reimbursement?
No, we haven't gotten into any of the reimbursement discussions yet. That'll
Okay.
be starting next month. And I forgot to ask at last month's meeting, but if anybody wants to volunteer for a quote to kind of end the meeting on, I did one last meeting. I fell through this meeting, but moving forward, if anybody has a quote that they would like to share, I think it's a nice way to end things. Nobody wants to. Oh, Betsy?
I have one. So in a discussion group I was in with a bunch of other nonprofit folks, we were sort of discussing how to navigate the world since the inauguration. And someone was sharing the story of her board, of which the director of NOAA is always a member, the National Oceanographic and Atmospheric Agency. And that outgoing person, when there's a new administration, that person always resigns. So the resignation was not unexpected. But in his last address to their board, he said to bear in mind the words "on course at speed," which basically means keep going, don't slow down. And I literally have that as a sticky note on my monitor right now, because sometimes it feels like we could get very stuck if we got distracted. So
Thank you, Betsy. I appreciate that. And if anybody wants to volunteer for next month, feel free to send an email with your quote. Would love to include it in the slides. And with that, I think we can move on to public comment. And I know we have two members of the public that will be commenting, and it is my job to call on them. So first up, and they'll have 2 minutes, Tom Sinsick. Feel free to turn on your camera, come off mute.
I'm ready. Thank you so much. Thank you again for your service. Thank you. You make my 8 years of work on this project worthwhile. So again, thank you so much. Very important. Everything is complicated and a lot of work, and you all know that. But the current system is untenable. Basically, I want to talk about two things: long-term care and the eligibility part. Long-term care, it was good that you came to the idea of you need something more, a task force and or a committee. I'm not sure how you define that, but keep in mind, there were 120 people that did not assign to one of these, that weren't assigned to one of these committees. So this is a really good place to go find the people, as was mentioned. It doesn't have to be you all. So keep that in mind. This will be very important for the upcoming budget proposal that you'll be discussing about. What is it that you need to get the necessary work done? So I want to just comment on that. And I think the health-related network stuff, the enhanced services are down a different topic, and I think you've started to cover that very well. So, and the issue of home care is always a big issue. It's ongoing for the elderly. Should they be cared for in their home? What are the costs related to that? What about a foster care situation? Again, those things are things to consider. So I'm going to move on now to the eligibility stuff. Basically, keep in mind to reference ORS 751. That's the statute. Basically, I guess that has to do with the enhanced benefits that I just mentioned. You do need clear definitions on resident or residing in. It was great to hear that. Hopefully, Washington and California will come on board eventually, and some of the border stuff will not be such an issue as we get to a bigger system. I have a lot of information about the requirements for university students. We've been studying that at PSU where it's required, and at OFU, University of Oregon, it's not required. It's optional, but they are paying lots of money. It becomes part of their student debt that they're paying for years and years to come if they're paying interest out of their student loans. And that's how a lot of people, and we're doing a study. I'd like to follow up with any of you on that. You can follow up with me about how we're looking at that work. We've got some analysis around the state about the different universities. We've already started that.
Okay, Tom, we're at time.
Okay, yeah, I'm good. Thank you so much.
Thank you, Tom. And Lou Siniger is going to be our next public comment. Feel free to come on camera and off mute.
Okay. Can you see me?
Yes.
I don't know why. Oh, there I am. Okay. Just a few things. First of all, again, I really appreciate all the work and really some struggles that you all are going through. And I really appreciate this. Don't forget that commercial insurance pays $1. Medicare pays 75 cents. Medicaid pays 50 cents, generally speaking. So this is going to be a boom to all providers because they'll all be paid the same. Nobody, no matter who you are, they will see you and be able to be paid the same. And I appreciate the work it is to go into the weeds and clarify this. The other thing I wanted to mention was being a retiree. I do have friends that retired from public service and they're taking their pension, they're part of their pension, but they're taking their healthcare plan with them. So that is going to have to be weeded out somehow.
The other thing is, don't forget the mental health part of the plans, especially, things like eating disorders and that type of thing. This is going to have to be figured out. And also, I just like to mention, I think there should be a study done on why it costs, $10 for little hospital booties or $6 or $8 for an aspirin. I think that has to be figured out and looked at. Why are they doing that other than money? And how can we somehow make this more reasonable? So I would just like to end. I look forward to being with this committee next time, and I will make probably a comment. I hope these comments are useful. And if they're not, let me know and I'll stop. Okay. Thank you again.
Thank you, Lou. Appreciate you both and your continued interest and engagement with the work. Thank you. All right. Well, I think that brings us to the end of our meeting today. If anything else comes to mind, please feel free to send an email to staff so we can be sure to include that. And then we'll be reaching out to those of you who did volunteer for those work groups. Thank you all for your discussion and time and service.